I think we can start. So, hello to everyone around the globe who's joining us for this special webinar on the Totem trial. So I'd like to thank everyone joining, and of course our keynote speakers, Dr. Luca Palombi, Dr. Linas Velichka, and Dr. Jan Stepansky for joining us today. I'll go quickly through the timeline of the session. I'll give a few words of introduction on the technical side regarding the tools used for this trial. Then we will have three lectures, the first by Dr. Palombi, second by Dr. Velichka, and third by Dr. Stefansky about the trial itself, results, and so on. Then an open debate on the role of phlebectomy given the results of the trial, and finally closing remarks by Dr. Palombi. In any case, you have questions during the session, please feel free to type them in as we go along in the Q&A box, and we will try to address them in the order they are received at the end of the lecture. In case we cannot complete the questions, I know it's a very, very interesting topic for today. Feel free to email us clinical@neolaser.com, and we will do our best to support and respond to any questions after the fact. So let us dive into the first segment, the technical piece. So regarding the trial, we'll talk about today the Totem trial. The trial itself came to be and was initiated with the idea that data accrued over the last years supports full systemic treatment of all vein types, potentially in one session. And from a technical perspective of development of tools, we asked ourselves as a innovator in the field and developer of devices and techniques, what does it mean really technically, and what does it mean to have one tool that allows you to do all of it in one session? The 3 points I wanted to focus on to explain this, one, and you'll see it I think in the results of the trial. One is the topic of efficacy, which I think correlates to what we call versatility, because here, instead of talking about a tool that would work efficiently and with high efficacy in the GSV or the SSV, we're talking about treatments of different segments, different lengths, different diameters, different geometries, where you, on some of them, cannot really guarantee good contact. So all of this translates into potential challenges in terms of the tool, and what you want is efficacy regardless of good contact. The second is the topic of safety, the ability to deploy the tool in a safe way, even below the knee in areas where you are close to nerves, close to the skin, across different anatomies and patients, and be able to control the direction and the depth of the damage, especially when we talk about the thermal tool. And the third is really the technical piece of being able to do this in a fast, repeatable way, meaning the access. So low profile, small tool, and we cannot escape also the economics of the specialty, meaning the ability to do this in a fast, repeatable, and a low-cost way in terms of access. All of this leading to the need for a small profile tool. So with this in mind, I would argue two things before we dive into the presentation themselves. One is that only a laser can deliver this type of combination of control. First, because a laser with the right wavelength, like we used here in 1940, is insensitive to contact, meaning the beam will continue to propagate until it hits an absorption medium, and as such, it's an extremely effective tool for the wide variety of veins treated. So this is point number one. Point number two is the ability with a laser to control both direction and depth of penetration of a thermal tool. This is an inherent part of laser energy and very difficult to replicate with other energy types. And the third is the ability to deliver it through very slim fibers, low profile that can be deployed through very slim needles. So all of these are properties which correlate with the topic of laser. And then comes the argument, okay, but how one laser may differ from another. So what you'll see in the trial today is a combination of the NUV 1940 and the infinite ring fiber technology. And our premise is that this is really a key piece that led to the results of this trial. because of the ability to control and the ability to give repeatable, safe results. Why? One, a laser where the wavelength is always stable, so the stability of the wavelength, that where you know where you emit in 1940, you keep on emitting in 1940. The second is the precision, repeatability, and stability of the power on patient number one, patient number two, between clinics, between boxes. This is from the laser side. Then from the fiber side, the uniformity of emission of energy along the vein, around the vein, all of this leads to repeatable results, safe, effective in the context of a laser. So I think this highlights the connection we would like to make between the tools used and the results of the trial. And now, honestly, it's really a big, big privilege. We're so happy to be able to be here after such a long effort by all of these distinguished researchers to publish and talk about the results. So my honor and privilege to introduce all three co-authors and researchers of this trial. I think between this group, the three of them, decades of surgical and clinical experience on the execution and the development of EVLA and venous treatment techniques, really with the long-term goal to perfect management of venous disease. So they will present one after the other, and as such, I'll do just a short few words on each one, and then you may pass it between you as we go on the presentation. So first will be Dr. Luca Palombi, really the initiator of this multi-site trial, co-founder of Cura Vena in Roma, and a private clinic Villa Saulus in Mestre, Venice, really a true leader in the EVLA evolution in the last years with numerous key publications. And founder, I think this is really important, of the Vein in Venice meeting, which is a platform for innovation. Following Dr. Palombi will be Associate Professor Dr. Linas Velichka, Chief of Vascular Surgery Department at LUHS Kaunu in Lithuania, really one of the pioneers in Lithuania of endovenous techniques in general, with thousands and thousands of minimally invasive treatments, more than 26 years of experience and huge focus on this area of EVLA and total EVLA. And last, but definitely not least, Dr. Jan Szczepanski, CEO and co-founder of Milius Clinic in Poland, focuses on vascular, endovascular, general surgery and phlebology, and really passionate about new techniques, treatment of chronic venous insufficiency, both thermal techniques, non-thermal techniques, hybrid operations, and close to 2 decades of experience in the field. So it's really a unique group of talent we have around the table. And I turn it to you, gentlemen. Luca.
Thank you so much. Thank you so much, Gil, for the kind introduction. I hope you can see my screen. Is it correct?
Yes, we can.
Okay, so first of all, good morning, good afternoon, good evening to everyone all around the world. I'm so glad to have the chance to start by not just talking about the results, but to have the chance to share my thought about what is behind the EVLA concept. So I would like to start today with a question that is why are we still treating only saphenous vein? This is a question that may be uncomfortable, but it is the concept behind everything. And the point for me is this: the reservoir effect. Over the year, we had the conception of find the reflux, close the trunk, and of course it works. And but despite all the advance and all the good results that we had, still we were observing recurrency. So the point is, when we all know the pathophysiology, the valvular incompetence, this lead to the dilatation of the collaterals, we do have to remember that venous is a system of capacity instead of the artery. We have two-thirds of our blood in the veins. So these veins are able to enlarge and create a real network and a reservoir. And this is the cause of the increased venous hypertension, microcirculatory congestion, of the symptoms of our patients, and also of the progression of the disease with the skin changes and the risk of venous leg ulcer. So let me say, treating the reflux without addressing the venous reservoir may be like say, okay, I close the faucet, but I leave the basement flooded and touch it. And for me, this makes really no sense. So probably this is the question, the wrong target. Are we facing this? For years, we have been focused on the treating on only the reflux saphenous trunk, and that's it. But perhaps the true target should be also venous reservoir, collateral networks, escaping pathways, and I mean the entire pathological anatomy that we face in that patient. And let's challenge a little bit our assumption, okay? I want to be a little bit provocative. In 2023 was published this trial called SAPTAPT, in which the researcher compared the results only after isolated ambulatory phlebectomy versus thermal ablation of the saphenous trunk with concomitant phlebectomies. And guess what about the results? In terms of quality of life and symptoms relief, there was no difference between the two groups at 6 months, but even at 12 months. So basically, they demonstrate with this trial that most of the symptoms were related to the collaterals and not just to the refluxive trunk. And if we go deeper in the results, they experience exactly the same improvement, no difference about this. But the other side of the story, and that's why we should address to the treatment for the saphenous trunk, for example, is that after 12 months, the group of only ambulatory phlebectomies in almost a half of cases, 42% had open and recanalized trunk with reflux, and in 24% of cases, 25% of cases, they had to receive, they received an additional trunk procedure. So let's move on and say, okay, this is just a trial, but we need more clear data about this. This is another publication. It's a systematic review on around the 7,000 limbs about treatment with concomitant on staged versus staged for the collateral varicose veins. And again, guess what? In the group of concomitant treatment, the reintervention rate was incredible lower, 6.3 versus 36%, with the same complication rate. So no difference in terms of complication. And again, the concomitant group experienced lower severity in the VUSISS. So basically, treating collaterals improve quality of life of the patient, symptoms, reduce reintervention without any adjunctive complication rate. And now, let's take a look at this really interesting publication by Dr. Lina Blomgren, in which basically they had a long follow-up of their patient for 8 years. And they were able to demonstrate how living residual incompetent tributaries increase not just the reintervention rate, but cause a severity of the disease that was comparable to the previous condition before the first intervention. And if we want to change a little bit perspective and be for once the patient, and as Professor Gandhi and Alun Davis have already shown in 2010, the biggest dissatisfaction from the patient point of view is the receive a second treatment for recurrency after varicose vein ablation. Okay, so you could also argue that we need clear scientific evidence. Well, ladies and gentlemen, in 2023, the SVS guidelines were pretty clear about the fact that if the patient referred to you with a truncal insufficiency and symptomatic collateral varicose veins, concomitant phlebectomies or foam should be considered with a class 2A recommendation. And again, you would say, yes, but it's a 2A grade of recommendation, which is exactly the same grade of recommendation that you have by treating the main trunk without thermal. So if you do eye ligation, channel chelate occlusion, MOCA, foam, you have the same grade of recommendation of those that treat concomitant tributary varicose veins. So now let's go to the second question. How do we treat it? And let me start from this. Innovation and evolution. We have assisted, to innovation and evolution over the years, especially in the last 25 years, in which a lot of new chants, new devices, new technique came out for treating and to address in the best way possible our patient. And so my question would be, so why we should stop this process? Why not to investigate how to treat in a better way also the collaterals? And if we take a look at what the literature is saying, this is a review that I've done for this webinar. Now we have two ways to treat collaterals: phlebectomies, mini phlebectomies, and ultrasound guided foam. And of course, they work well. We have good results, but still we have some problems that we have to deal with. Not just the recurrency rate, but also some complications such as hematoma, hyperpigmentation, superficial vein thrombosis, sometimes skin necrosis, infection, neurological complication, systemic and local, deep vein thrombosis, the request sometimes of having good cosmetic results. And so this is the reference of the review that I've shown you in this moment. So why not to try to look for something that probably could help us in addressing better that specific patient for a treatment also of the collaterals. And the EVLA concept is just about this, not just treating the main reflux trunk and perforator vein, please, when incompetent, but also side branches varicose veins. And this is a short video. I will keep it fast just in order to stay on my time. I normally study the patient. The type of reflux, as you can see in this case, was a clear terminal valve incompetency with a reflux also on the epigastric. So for these cases, I normally proceed with flash ligation. As you can see in this case, there is on the posterior part of the vein a little bit of blood trapping and enlargement. I always try to create the good contact between the fiber and the vein wall in order to reduce blood trapping and discomfort related to this after the procedure. And then the ablation is a classical standard ablation. For the collateral treatment, normally I try to navigate the vein as much as I can. So I don't like to place 30 needles in the leg because I don't think it's really invasive. So normally I use all the length of the needle that I have, normally 7 centimeters, but I also use some adjunctive catheter. There are, I do use 4 French long introducer with the guide wire. So sometimes I try to navigate also the collateral varicose vein and advance my long introducer and then the fiber. When I face perforator vein, normally I try to plan on the perforator vein at the level of the fascia by using also the varicose veins that are connected with in order again to reduce the number of puncture if I can, To do this, of course, you have to move your probe on the plane, on longitudinal, sometimes in transfer projection, in order to reach only the lumen of the vein. When the varicose veins are small, here is the challenge. You need to move really frequently your probe and try to stay intraluminal. Nothing happens if for less than 1 millimeter you are outside. This is my experience. As I said, when there is a perforated vein, normally I place the needle really close, as close as possible at the level of the fascia. But by using the collaterals in order again to reduce the number of the needle that I have to place. And sometimes when the collaterals are really small and tortuous, I use more the transfer projection in order to be sure to be as much as I can always intraluminal. But again, I'm not so worried when sometimes it happens that you are a little bit outside. Tumescent anesthesia is the key for the contact of the fiber with the vein wall, and this is great to reduce the energy that you have to deliver, and of course to protect the surrounding tissue and the skin. I do not count and watch the screen during the procedure. Now it's really long time that I perform a TIVLA, and what I like to see is just the image coming from the ultrasound and feedback that the fiber gives me during the ablation. Sometimes you need to go multipass in order to avoid not uniform treatment that could lead to inflammation and phlebitis or superficial vein thrombosis, which is something that we would like to avoid in order to reduce complication rate and especially pigmentation after the treatment. And so this is how normally I perform this procedure. At the end of the procedure, I always place a specific class 2 monocollant for 7 days and for 48 hours, days and night. And I always perform the check after the whole procedure. And now let's move to the last part. So please, Gil, accept this. When we talk about TIVLA, the laser is not the innovation. When we talk about TIVLA, the innovation is the strategy, which is created by a different philosophies, as I show you about the concept of treating the reservoir. But of course, to do this in the right way, you need the right tool. I started at the beginning with the 14-17 nanometers laser, but I have no doubt what to use in this moment. And you don't have to believe me, but to believe what the literature is saying in this moment. Only in 2025, we had 2 really good studies head-to-head, comparing 1470 versus 1940. And what came clear also from this was that you need 30% less of lead, you have lower pain after the procedure and less risk of neurological complication and heat thrombosis. All good reason to switch your procedure on this new wavelength, especially for TIVLA. And now also we have a new chance. Thanks to also Neolaser and the effort that they are pushing on the development of new tools dedicated for TIVLA. We now have an infinite fiber of 500 microns with the entry profile of 1.2. What does it mean? The entry profile of the standard 400 microns, it's 1.3 millimeters. So this new fiber has a little bit lower entry profile, so perfectly fit in the 16G needles, but you have more extra support given by the 500 microns of the fiber, which is great when you have to face simultaneously a main trunk, which sometimes could be really big, and small collateral veins. So really a good tool. And also with this fiber, you have the infinite ring emission, which really it's a nice tool to have an homogeneous treatment and also to spread a little bit the heat and temperature over the firing zone. And now we are moving to a new fiber, which is even smaller. It's a 400 microns fiber with an entry profile of 1 millimeter. So you can address this fiber in an 18G needle. And especially if you move to other aesthetic territory in which you want to use EVLA instead of foam, and we can discuss also about this, but you have this chance with this new fiber. These are some example of the usage of these two tools for the TIVLA procedure. And I'm really satisfied about the results with these new devices. So in the end, is this the end of the phlebectomies era? Well, I think not yet, but we are going in that way. Thank you so much.
Thank you so much, Dr. Palombi. And I welcome Dr. Velichka to share the presentation.
Okay. Hello, everybody. I am happy to be here and to share the results of our trial, which was done together with my friends Luca and Jan, with the support of NeoLaser, and also those who left behind this scene. So in my team, it was Arnolda, Maria, and so really it's happy day for us because it's the first publication about multicentral total EVLT trial. So if we talk about population, it's we should treat as a doctors working in phlebology field. We should treat a lot of patients. It's only less than 10% of population has no signs of varicose vein disease or chronic venous disease, and about 31% of population has potential need for tributaries treatment, which Luca said in previous presentation, looking from another point. But still, it's a lot of patients who should be treated, not only the trunk, but also the tributaries.
Dr. Velichka, if I may interrupt, may you move to full screen? I believe we see just a welcome slide at the moment.
You do not see my screen?
We see the screen in not in a presentation mode. But we see the sequence of slides on the left and the main slide, the Totem trial early results that may change the game in the middle.
Okay.
If you can hit the...
I do next sharing. Do you see my... Now it's okay?
I believe so, yes.
Okay, so should I repeat? Or it was some...
No, it's okay. Just which slide are you on at the moment?
You can see?
Yeah, the contemporary clinical practice.
Yes.
Please continue.
Okay, so sorry about technical issues. Our contemporary practice comes from the guidelines, and we see that in all guidelines looking to trunk is everything clear, but about side branches, it's only two treatments, sclerotherapy and mini phlebectomy is recommended, and the recommendation for this is quite high. So why not we should do the two-in-one treatment? That means that using the same technique, the same laser fiber, the same laser machine, but doing everything with a laser simultaneously, and Usually we name this total endovenous laser ablation. So why EVLT for tributaries? The idea was that superiority of sclerotherapy is laser induces instant up to 40–50% shrinkage of vein lumen, transmural damage of vein wall, no risk for sclerosant systemic effect, because about 25–30% of population has foramen ovale open. Precision of ablation, if we want to save non-refluxing trunk, no or less need for 2–3 week compression stocking therapy, and of course it's better to treat large veins. Superiority of a mini phlebectomy, no cuts, always sounds better for our patient, less risk for infection. When we treat tributaries in an infected area, less risk of seroma and lymphocyst. Postphlebitic tributaries, less risk for nerve damage, especially for recurrent veins when we have very fragile vein wall, recurrent vein wall, less adherent to compression. We can treat easily patients on anticoagulation, and of course, obese patients. When we think about this and having no data, scientific data, so always when we talk with colleagues, so it's fears that it could be skin thermal damage, hyperpigmentation, paresthesia, postoperative pain, and probably a longer procedure. So we did this trial, 3 countries, Italy, Poland, and Lithuania. And it was 50 consecutive patients from each center, C2, C6. Study design, multi-center prospective, non-randomized, non-blind clinical trial, and equipment laser fiber, laser 1940 and fiber 40 micron, infinity ring. Study patients, we have 158 patients. Age mean was 22.7, median 55.7, sorry, and the median 55. The majority, as usual, it's female patients, 76%. 76 patients and 64%. There was no thrombophilia, history of superficial vein thrombosis in 12 patients, history of DVT in 1 patient, obesity about 30% of our patients. The venous clinical severity score was 7.7. The main patients, they were C2, C3 class, and that means that the majority of our patients, they have the aesthetic result, it's really meaningful for them. Right limb was in 47%, left in 52%, GSV in 83%, anterior saphenous vein almost 17%, short saphenous vein in 14%. Intervention. Maximum vein diameter mean was 10.6 plus minus 4.8. Diameter at 2 centimeters from junction was about 8.5. Targeted length mean was 33.6. Number of 14G needle cannulas 3.4. And total tumescence was 300 42 plus minus 260. So variability is quite big. And laser fiber set parameters was that mean LAD was 45.32 and power 5.2. LED for tributaries 26.5 and power 3.8 watts. We observe almost 100% occlusion rate, and this persists for 6 months. After the treatment, we see that mean change of 3.4 points in the revised venous clinical severity score with statistically significant improvement. And among 57 patients with 6-month follow-up, mean revised venous severity clinical severity score decreased from 8.53 at baseline to 5.4 with a mean change of almost 3.5 points. Secondary endpoint is AHIT. It was no observation of AHIT, despite that some centers perform laser crossectomy, so on the level ablation of the level of femoral vein. Deep vein thrombosis 0, superficial vein thrombosis only 1 patient, 1.7%. Paresthesia 2.6%, hyperpigmentation in 9 patients, 5.9%, no bleeding events, and post-procedural pain at first follow-up 7 days after operation was low, with mean score 1.39. And the paresthesia and hyperpigmentation, it was of special interest for us. So paresthesia rate after VLT only for truncular veins are typically reported about 3%. And following ambulatory phlebectomy may range widely from approximately 9.5% up to 40%, depending on technique, if we look to guidelines. Hyperpigmentation rates in our trial was 5.9%. So from the literature, we know that 4.6 following phlebectomy and 10-15% after ultrasound guided form sclerotherapy. I tried to compare from Lucas, one of his numerous publication. I took this meta-analysis, and this is the results of lasers 19 and 1940 wavelength, and comparing our results with this very recent publications. The occlusion rates is very high. Then the AHIT was 0 in our study. Neurologic complications were very competitive and very low. Hyperpigmentation, we have more. That means 5.9%, and thrombophlebitis, we have only 0.7%. So also the very low, except this hyperpigmentation, which could be expected doing everything with the laser. And when we compare the groups with higher and lower leads for side branches, we see that the paresthesia and hyperpigmentation has no is not linked to the higher energies. So conclusion, the Totem trial demonstrated that EVLA is a safe and effective approach for the comprehensive treatment of chronic venous disease. The absence of significant association between higher LAD and the occurrence of hyperpigmentation or paresthesia, together with complication rates compatible to or lower than those reported for established techniques such as ultrasound control, sclerotherapy, and phlebectomy, supports the adoption of this strategy in appropriately selected patients. Further randomized studies with longer follow-up are warranted to confirm these findings and to better define the role of EVLA with current treatment algorithms. And coming back to these fears, the skin damage is really not a problem. We do not see this. Paresthesia is very low. Postoperative pain is low. Longer procedure is compatible with the timing in experienced hands. Of course, some higher than with mini phlebectomy trials, hyperpigmentation in the very, very technically selected centers, but in general is compatible also. And I saw this on LinkedIn publication. Does total level T is innovation or is total bullshit? So after this trial, I would like to say that the EVLA is the data from Totem trial suggests that total level T is feasible, safe, and effective. Thank you for attention.
Thank you so much again, Dr. Velishka, for the great summary of the trial. And yeah, great results and very interesting. We turn to you, Dr. Stepansky. Yes, we can see the presentation.
Do you see this?
Yeah, all yours.
So at the beginning, good morning or good afternoon for everyone. And thank you so much for giving me the opportunity to be part of the Total EVLA study and this webinar. Honestly, this is a team achievement. It belongs to Jill Dilbel, Fabio Martinelli, Maciej Jaworski, and three of us, and many other behind the scenes. And I'm deeply grateful to all of you and proud to be part of the amazing journey together. And thank you for the opportunity to share a practical view of Total EVLA. I will not repeat that Total EVLA can work. Luca and Linas have already said the conceptual and clinical background. My task is different. I want to show where Total EVLA works in daily practice, where it becomes technically demanding, and where we should stop because the tissue field of the network is no longer safe or predictable. Oh, sorry, something bad has happened once again. Once again. Okay, I've got it. Uh, this is the first point is conceptual. The wrong question is, can every tributary be ablated? In real practice, that question is too narrow. The better question is whether the reflux network can be controlled. A varicose limb is not usually a single vein problem. It is a pathological network with sources, escape points, dominant pathways, the superficial branches. Total EVLA starts by changing that mindset. Uh, for me, mapping is not simply a preoperative drawing. Mapping is the procedure before the procedure. It tells me where the sources are, which pathways are dominant, which segments matter clinically, and which tributaries can be safely ignored. If mapping is weak, total EVLA becomes blind puncturing. Uh, if mapping is good, every complex anatomy becomes a structured plan. Many perceived limits are not true limits. Tortuosity, superficial course, and thin subcutaneous tissue are often technical difficulties rather than contraindications, in my opinion. The operator must separate the difficult access problem from a true limitation. A true limit appears when the network cannot be controlled reasonably, when the access burden becomes excessive, or when the tissue field is unsafe. This ultrasound clip illustrates the tortuous tributary. Tortuosity alone is not main limitation. If the vein is visible, if the segment can be planned, and if access can be achieved under ultrasound, the anatomy can often be treated. In my practice, tortuosity separates basic EVLA from advanced total EVLA. It does not automatically exclude treatment. After ultrasound mapping, the strategy becomes segmental. I do not try to force the fiber through every curve as if every vein had to behave like a straight truncal vein. Instead, I divide the anatomy into short treatable segments, choose access point deliberately, and focus on clinical relevant pathways. The goal is not to ablate every centimeter, but to control the functional network. This is where total EVLA, just a moment. This is where total EVLA becomes very operator dependent. The puncture is not theoretical, it is a real procedural skill. Stable probe position, sure control access, and continuous ultrasound feedback are, in my opinion, essential. If access is imprecise, the whole strategy becomes unstable. If access is controlled, every demanding tributaries can be treated safely and predictably. This is a concept I often describe as skewering. Curved tributaries can be treated segmentally, skewering, or from Russian shashlik. We should not force the vein into a classical long straight cannulation model. Multiple short entries may allow treatment of dominant curved segments. The important point is to ablate the segments that carry reflux and create visible disease rather than chasing every small residual branch. Another perceived limitation is superficial position. I do not consider superficial location alone a contraindication. It is a risk factor. The risk is thermal injury to the skin. The practical solution is tumescence. We need to create distance, compression, and thermal protection. If a stable safety layer cannot be created, the clinical decision changes. And tumescence is much more than anesthesia. It creates the safety geometry of the procedure. It separates the skin from the vein, compresses the vein, reduces the volume that must be heated, and protects the dermis from thermal injury. The essential issue is not simply how much fluid we inject, but whether the fluid is in the correct layer and remains stable during ablation. In most patients, volume is rarely the practical limit. Of course, we must respect cardiac and renal status, and we must monitor lidocaine dose if lidocaine containing tumescent is used. But in a fit patient, 2 or 3 liters may already be extensive and still clinically well tolerated. The key question remains, where does the fluid go and does it create a safe layer? And this is the central practical limit from my point of view. The laser can close many tributaries. The difficulty is not usually laser efficacy. The difficulty is access burden and three-dimensional network complexity. Multi-layered tributaries, small caliber branches, variable depth, and too many reasonable access points. And some point, the question is no longer whether the vein can be closed, but whether the procedure remains rational. Every extra target has a procedural cost. More access points mean a longer procedure, more puncture trauma, more demand on mapping discipline, and greater operator responsibility. This image is not a trophy, it is the practical cost of ambition. Network control is not obsessive puncturing, it is choosing the segments that change the chemodynamic and technical appearance, in my opinion. And this is why do not need to ablate every small branch. If we close the main sources, treat the dominant pathways, and ablate clinically relevant tributaries, many smaller residual branches will collapse, shrink, or become clinically irrelevant. The aim is predictable collapse of the system, not perfection on the skin map. And what else? The total EVLA works best when the network is controllable. That means that source is clear, the dominant pathways are accessible, and tumescence is stable. Ultrasound visibility is good, and laser control is possible, and the skin is for sure protected. These are the cases where total EVLA gives a fast and elegant result. There are 3 real limits. The first is a network that is too complex to control in one session. The second is access burden that becomes unreasonable. The third is an unsafe tissue field. When one of these limits is present, the correct answer is not heroic persistence. The correct answer may be staging, delay, or another technique. Mm, This is the biological safety boundary. Active ulceration, an unstable wound, fragile inflamed skin, infection, or an unsafe puncture field changes the decision. This does not necessarily rule out treatment of proximal reflux through safe access points, but it is a strong reason not to perform aggressive multi-access total EVLA through damaged field. This is not a laser limitation, and I think this is a tissue biology. This healed complication is an important reality check. Total EVLA is powerful, but this is not biological neutral. If the protective layer is insufficient, if the vein is too superficial, or if local tissue tolerance is exceeded, skin injury can occur. And this lesson is not abandon the method. The lesson is to respect the safety boundary and avoid treating every visible branch at any cost. This leads naturally to the question, is phlebectomy dead? My answer is no. But its role is narrower. Total EVLA expand that we can treat endovenously, but phlebectomy remains useful when direct network control is unreasonable, or when the anatomy and tissue biology make laser strategy less predictable. The debate is not laser versus phlebectomy, it is strategy versus habit. And my take-home message is simple. Most tributaries are treatable, but not every field is safe. The real limit of total EVLA is not usually the ability of the laser to close the vein. The real limit is the network control, access burden, and tissue biology. The future of this field is better mapping, better tumescence, better staging, and better judgment. And thank you for your attention.
Thank you so much, Dr. Stepansky, and we move on to the panel Q&A. Should we, Dr. Columbia, start with the questions sent by the audience? Or
Yes. We are here for the colleagues and to have the chance to discuss.
Okay, so let's see. Question number one. I believe you also see the question, how to treat intramuscular SSD branch.
Well, intramuscular, it's we can discuss about this. I mean, normally I treat perforator veins at the level of the fascia at 0.5 1 centimeter in the fascia, not more than this. And no, as I show in my presentation, normally I try to plan to the perforator from the collaterals and try to place the needle at a little bit inside the fascia. So I think this is how I would do that. And I don't know what the colleagues think about this topic.
I completely agree with you that for those perforating veins, it's really a fantastic tool in case if the anatomy lets us to do the puncture. So, but the depth of positioning is below the fascia, And starting from this point is usually what should we do? So we should be two things. We should have very good tumescence because the tissues under the fascia is extremely painful. And the second is that we should start from stay and burn and then move, because to leave the energy of laser, we have very limited space. So we should, in very short distance, we need to put enough energy.
And I would like to answer the question for the question of Piotr Marciniuk, who is my colleague, and in Poland. And thank you, Peter. And tributaries lead was calculated in the same way as a truncal vase based on delivered energy per treated segment length. Regarding paresthesia in this retrospective real-world study, we did not specifically differentiate truncal from tributary related paresthesia. We assessed paresthesia as a clinical endpoint regardless of its exact anatomical origin. That's my answer.
Yeah, the same. I mean, the how to calculate the lead. Jan already said there is no big secret behind this. It's pretty easy. Regarding the paresthesia, that would be another interesting thing to do for the long-term results, 12 and 24 months results after the trial, because most of the cases, I had one cases in my center, and after 6 months, the paresthesia is completely solved. It was on the territory of the saphenous nerve. But that would be interesting to understand if it's more saphenous or collaterals. But probably, that's my experience. It's even safer to treat collaterals that the distal part of the GSV, in which you have to be more careful with the energy that you deliver, with the tumescent anesthesia that you have to deliver, and sometimes even with the tumescent, because sometimes it's the needle that you use to give tumescent anesthesia the problem, because you can puncture the nerve. So this is really the other side of the story. I mean, probably it's even safer treat collaterals with the laser than distal parts. So it means that this procedure is really safe.
Completely agree.
And Roman Kartasov is asking, is there still a role for the good old combination approach of endovenous laser ablation and mini phlebectomy? In my opinion, absolutely. Mini phlebectomy still has a role, especially in very large, superficial, and highly tortuous varicosities. However, our experience with total EVLA shows that many veins previously treated by phlebectomy can now be managed entirely endovenously with less trauma and excellent patient satisfaction. So, why use it?
May I add something about this? I mean, I think that today we are not saying that if you perform extensive phlebectomies, you are doing a wrong thing. First of all, as Jan said, the point is venous mapping and understanding exactly where to start and where to finish, which is the dominant varicose veins for that reflux and for that disease, because we are treating a disease. This is really important to stress. But so you can still do phlebectomies. But what we are trying to say is that, as what we have observed for truncal ablation over the year, a lot of new tools, new devices, new techniques have emerged and gave us the chance to treat it in a more tailored way. And I think that this technique is going in this direction. It's showing us promising results, comparable results, and low risk, even lower risk respect to what we are using from like 50 years or more. But the point is, for me, is also the diameter. In 2026, with a collateral of 4 or 5 millimeters, I will never do any more phlebectomies. That's my point of view.
If I can add to this, I completely agree with Luca and Jan. And personally, I think that again, in nowadays, the excellent, what is excellent phlebologic treatment? That means that there is not a hammer in the hand and all we see is nails, but we have a lot of tools and we delivering a la carte treatment for our patients. So we can have the same anatomy, the same obese patient, but one of them has huge veins, obesity, but he's extremely interested in aesthetics. So he's extremely interested in not having the hyperpigmentation. And the next patient who wants to, the only thing to get rid of the symptoms and the aesthetics does not play for him the huge role. So in those cases, you can choose which tool to select. The anatomy and the constitution of the patient will be the same, but we need to talk, we need to listen to our patients, what they want, what they expect. We need to clarify for them our results. And also we can, now we have possibility to select and to find those who have the tendency for hyperpigmentation. So in those cases, we have the more space for choosing our treatment and making a strategy in advance.
Someone is asking for about the hyperpigmentation. My answer is simple: time and patience. Most hyperpigmentation fades spontaneously, and in selected cases with retained thrombotic material, needle evacuation can help speed up the process, and that's the answer.
Yeah, as the answer is what you do after hyperpigmentation, after foam.
Me or this guy?
No. It's for the colleague that asked the question. I mean, if you can experience hyperpigmentation even after foam, and so after foam, what would you do? Compression, creams, evacuation, aspiration. You do the same.
Okay. General question on the length of the procedure and the amount of anesthesia.
How long does it take? I think that I've done also a review to understand, the procedural time of other technique, and also respect to my experience, everyday experience, doing EVLA plus phlebectomies or other technique plus phlebectomies. I mean, I think that the time, if you do phlebectomies in the right way, so you are gentle with the tissue, you take time to take all the veins off and not leaving part of this inside because it could lead to hyperpigmentation or inflammation and so on. So if you do phlebectomies with the good attention that you should, exactly the same time, no more. Of course, if you compare with foam, it's more time.
Hua Chen is asking, how could we confirm a tissue field is safe? By combining several factors, adequate tumescent anesthesia, creating a protective fluid layer, continuous ultrasound guidance, keeping the fiber centered within the vein, and avoiding excessive energy delivery. In practice, safety is achieved by respecting anatomy and continuously monitoring tissue response. Safety comes from proper tumescence, continuous ultrasound guidance, and adapting energy delivery to the anatomy and tissue response, as I said.
This relates to the tissue safety aspect. Any additional piece on this, Dr. Palombi, or continue?
I mean, be gentle with the power button, but I think that in my experience, the good way to understand if you are doing a good job in a safe way, it's to do all the procedure under ultrasound. And if you are in the vein, you can observe some bubbling moving in both direction of the vein. So it confirms you that you are inside the vein. Sometimes when you are outside the vein in a part during the cannulation, you don't see this phenomenon. So what I do in this case, I see by ultrasound and I skip a little bit that part and then I start again the ablation. That's what I would say more than John said.
Yes, and probably the second point is that, like usually, we need to have a time and to marry our equipment. So if we changing machines, changing fibers, so to get this haptic feeling or sounds in tissues and ultrasound pictures, it makes more difficult. So for faster getting faster the experience and knowledges in new techniques, usually we need to have the same machine, ultrasound and laser. I think we missed one of Dr. Bichkauska's question about delayed sclerotherapy after just doing EVLT and then sclerotherapy. So my point of view is for this is in general the two things, because if we want to get a good result symptomatic patients, so what Lucas said about venous reservoir, like we have in pelvis venous reservoir, also we have venous reservoir in the leg. So if we close this reservoir at the first session, so we definitely will have better feelings, better results instantly after the operation. And especially this connects for the patients who have trophical lesions, even ulcers or hyperpigmentation, because we have these studies that if we are quite aggressive on treating venous reservoir, so we can get rid of even C4 disease. So, or not get rid completely, probably to relieve this hyperpigmentation and lipodermatosclerosis partly. So my point of view, I want to do everything in one session as much as possible.
Yeah, I would just like to add the one thing. I mean, I think that CAP class it's a key for this decision, about treating or in concomitant way or not. And in CAP C2, you can consider this. Also, if 20% of cases is not that low. But if you talk clear with the patient and you have an agreement also on the possibility to have a second treatment, it's okay. For me, in the public system in Venice would be a little bit difficult because we have a waiting list for the procedure. So not that negotiable sometimes with the patient, but it's okay. For C-up, C4, C5, or C6, I would like to be aggressive because the risk of progression, recurrency of venous leg ulcer, it's really high. And we do know that a crucial role is played also by the subalcer venous plexus. So leave that reservoir so available for that plexus. I mean, I think it would be not my choice.
The same. Let me answer. Let me
Mhm.
answer for the question of 1940 of
1470.
possibility of the 1940-70 nanometers wavelength laser, because I do it because of working in a variety in a few clinics, and some of them I have a possibility to work only with laser 1470. And I would like to say absolutely yes. I mean, it's quite possible and to do total EVLA with 1470. It's entirely feasible. The key is not only the wavelength, but also experience, meticulous ultrasound guidance, and individualization of the energy delivery. And that's the simple answer for that question, in my opinion.
Would you take a different, let's say, a bigger safety zone in terms of distance from skin, distance from, certain, areas where you say I would do it with a 1940, but I would avoid it with a 1470?
The most important, in my opinion, is individualization of the energy delivery, because we have to lower down the
Mhm.
energy, because this energy is much more aggressive than in 1940. That's my opinion, and I do it, and I think I do it with really good outcome.
Uh, I agree with Jan, and my beginning of the journey in total level T was 1470. But now I would say that if I have patient something to do more in the lower part of cruris, or even in pedis, so the 1940 will be the only choice for me.
Yes, that's the clue. That's the
Yeah,
clue. If possible, 1940 is much better. But if you don't have any choice, okay, you
sure,
can do this.
sure, agree.
Okay, thank you. I think the next question on anti-coagulant treatment post-procedural, which and how long?
Yeah, that's a topic. I mean, we should discuss about what we think, the indication, and the country in which you work.
Mhm.
I'm saying this because we do have also national guidelines and recommendation, and to be honest, that's a consideration that I always have to deal with. Normally, we give low molecular heparin after the procedure for 7 days. I know that you should stratify by the international guidelines with the Caprini score, which patient to anticoagulate or not. But to be honest, also now there is a big trial that is going on, and probably next year we will know something more about this. I will thank for this Professor Alun Davis. But from a lot of survey during over the all Europe, 75% of Irish colleague prescribe anticoagulation,
Mhm.
more than 75 in Greece. In Italy, I would say like 90%. And I don't know what about in your country, but So my answer is yes for 7 days.
Yeah, and it's very interesting experience because we know that the recommendations they say about stratifying the risk groups. But if we come to something like Delphi consensus or coming to voting during conferences, so voting will be what Lucas said, more than 70%. I've never seen in any voting that less than 70% will say we are not using the anticoagulation. So usually this anticoagulation we use in my practice, I am using always in very special situations for very young patients who do some activities, then probably not. But and as I know, the most of my colleagues they do the same 1 week of perioral anticoagulants, prophylactic dose.
And in our practice, I mean, here where I work, I mean, in my Melis clinic or in other clinics where I work, we routinely prescribe prophylactic dose low molecular weight heparin for 10 days after total EVLA. And we believe that the extensive nature of treatment and multiple treatment segments may justify this approach, but and especially about the well-known score. We do not routinely use topical heparin gels or NSAID patches, although they can be helpful in selected symptomatic cases, but routinely only heparin for 10 days.
I think we received also from additional indication from additional countries. India, 5 days, Switzerland, 7 days. So sounds
We prescribe for 10 days because there is a 10 doses in a pack. That's why.
Okay, I think the next two questions on the power and dosages and so on. First, I think we spoke about it a bit, and maybe it's a good opportunity to tell the audience that the publication is actually out and open access to everyone. So feel free to find the publication. We can send the link later to everyone and simply go through the paper. I think this will be probably the best guide on power levels, ranges, and so on. So I think I'd defer that to simple reading. Courtesy of all of us, the publication is open access to everyone, so easy to access and read. In addition, just to use the opportunity to say if any physician would like to learn the technique in a more intimate way, please contact us in terms of potential workshops or ability to learn this in a deeper way. I think the last question had to do, I see it came in on cold tumescent, or it is 8 degrees. Does it help? Does it matter?
Let me just add this thing, Gil. I think that the good thing of Totem trial is the fact that until it came out, we had no publication, no perspective study on total EVLA, and also not standard parameters to refer. In this moment, we have a clear way. So if you, of course, everyone has his approach. Over the year, with the learning curve, you could adjust the energy. You can make different choice. But especially if you start the treatment, if you are at the beginning of the learning curve, have a reference. It's everything. And so please, if you're really interested in that, go on the JVS open access publication, and you can find the answer. Regarding the two missions, yes, we use cold saline, refrigerated saline which is amazing tool, not just to protect the tissue, but also to create the spasm of the vein, which helps the contact between vein and fiber.
In our practice, we do not routinely use cold tumescent anesthesia, just from time to time. It depends on if I have a fridge somewhere in our surrounding. But proper tumescent volume and ultrasound guided perivenous protection seem to be more important than temperature itself. However, cold tumescent may theoretically reduce inflammation and post-procedural pain, and I think it deserves further investigation, in my opinion.
I think that if I am right, that we have already the investigation of this on cold tumescence and warm tumescence. And actually, it was even with those hemoglobin lasers, which were more aggressive from the point of view of neuropathy. So there is a difference between cold and warm tumescence. So probably in 1940, we really do not need, but this cold tumescence comes from this aggressive old times.
Yeah. Interesting. Yeah, I would assume lower wavelengths that, in essence, generate more dissipated heat into the surroundings would be impacted in a more pronounced way by this. So it's an interesting question to think about. Okay, gentlemen, I think you've done an amazing job in addressing multiple points and everything that was asked on this pivotal trial. Luca, turning back to you to close the session.
Yes. Okay. Okay, do you see my screen?
Yes.
Okay, so first of all, thank to all the colleagues that were connected for almost 1 hour and a half. And I think that with this course, this webinar, it's really important because we are now switching a little bit we are going to something that probably at the beginning was more uncomfortable. Some years ago, talking about total EVLA was really something you have fear to do and to worry about the answer of the colleagues. And now it's on the wave. We have understood that it's safe and effective. It could be done if done in the right way, could really be helpful for us and for our patients. So we were challenging the dogma at the beginning, and I think that in this moment there is no more doubt about the fact that it's safe and effective. Probably now the other dogma would be in the next few years if this technique will replace phlebectomies or foam. Who will see? We will see. My perspective and my wish was to deliver a message, not just on the TIVLA, but about treating our patient not just for refluxing trunk insufficiency, but also consider the reservoir, which is a really important concept in my mind. Linus had showed us the results, which are available with the open access publication. So we are waiting for all the questions after your reading of our effort for this publication. We have discussed, and Jan started in a great way, the indication, even the limitation of the technique, because at the moment still. But I think that nothing fits perfectly for all. So we should consider also cases in which to avoid performing EVLA. So patient selection remains essential as usual in surgery. And by closing this take-home message, phlebectomy is not dead, but the rule is changing, and probably even in the future we will assist to performing even isolated laser phlebectomies. So this is what I think. Then let me say a big thank to NeoLaser and to all the people that in these 2 years came in my facilities and with a lot of energy and with a lot of willingness of learn, grow together, change our dogmas, and of course learn from each other. I have met a lot of great colleagues coming from all around the world, from Australia to Canada and all of Europe, but also Suriname. And so I'm so grateful for this. And I can't wait to see what will come in the next months. And I will be really glad to have all the colleagues that would like to join our workshops. And a special thank to another friend that I will not mention now. Thank you so much.
Thank you so much, Luca. Means a lot. And thank you, Dr. Velichka and Lina Sinyan for the presentations and the material. I think it was extremely educational and contributing to the whole community listening to us. To the audience, I'd like to thank you again for joining us on this weekend. And if you have any further questions, again, feel free to contact us at clinical@neolaser.com. We'll be happy to support as much as we can. And thank you so much, and wishing you all a great weekend.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye.